In this presentation, we will cover athletic-related sudden death as it pertains to sickle cell anemia. During this presentation, we will review basic hematology as it pertains to sickle cell anemia. We will define and differentiate sickle cell disease and sickle cell trait. We will then describe the epidemiology of sickle cell disease and sickle cell trait. We will also list complications of sickle cell and discuss their role in athletic participation in those affected. We will then outline current measures in prevention of sudden death due to sickle cell during athletic participation, highlighting key components of recognition of sickle cell attacks. We will discuss treatment and management of acute sickling events and highlight important considerations for athletic trainers. Red blood cells are the cells in the blood that's main function is to carry oxygen from the lungs to the tissue and remove carbon dioxide from the tissue and transport it back to the lungs. Each red blood cell carries a hemoglobin protein. The hemoglobin protein is an iron protein molecule that binds oxygen for transport. When oxygen is bound to the hemoglobin, it is called oxyhemoglobin. After releasing the oxygen molecule, the hemoglobin is referred to as deoxyhemoglobin. Oxygen saturation refers to the percent of hemoglobin in circulation that have bound oxygen to them. When this ratio decreases, the working tissues are not receiving enough oxygen to function optimally. Oxygen saturation is commonly measured on the finger with a pulse oximeter, but is more accurately measured with a direct blood draw. Healthy normal red blood cells are smooth, flexible oval biconcave discs, as pictured in the top right-hand corner. Sickle cell disease is a codominant genetic disease that causes the body to produce abnormally shaped hemoglobin. The abnormal hemoglobin does not bind oxygen as well as normal hemoglobin and causes the red blood cells to become misshapen and less pliable and flexible. The crescent-shaped or sickle-shaped red blood cells have a much shorter lifespan than regular blood cells, as they are destroyed by the body's macrophages and the spleen. The shorter lifespan of these cells results in anemia, or a deficiency in red blood cells or hemoglobin in the body. These abnormal red blood cells also adhere to the walls of vessels, occluding small capillaries and venules, restricting blood flow. These occlusions result in acute painful events referred to as vaso-occlusive crises that occur at different frequencies and last for varying lengths of time in each individual. Those with sickle cell disease have a reduced exercise capacity due to ongoing lung damage due to sickling cells and diminished oxygen carrying capacity and myocardial ischemia. Despite the challenges of exercising with sickle cell disease, those with the disease are still encouraged to participate in light exercise. This will be covered in more detail later in this presentation. In order to understand the difference between sickle cell disease, which we just covered, and sickle cell trait, it is essential to understand the genetic makeup of those with sickle cell disease and sickle cell trait. A subject's genotype is the genetic constitution of an individual organism. In this case, what type of hemoglobin allele is present. Phenotype is the set of observable characteristics of an individual resulting from the interaction of its genotype with the environment. In this case, the phenotype is normal hemoglobin, sickle cell trait, or sickle cell disease. The allele for hemoglobin may be either HbS for sickle or HbN for normal hemoglobin. Both of these alleles are dominant. When a mother and father both contribute HbN alleles, as seen in the first row of the table, the resulting offspring will have a normal hemoglobin. If the mother and father both contribute HbS alleles, as seen in the bottom row of the table, the resulting offspring will have sickle cell disease. However, if one parent contributes a normal allele and the other an abnormal allele, both will be expressed, resulting in codominance of the individual dominant alleles. This individual is referred to as having sickle cell trait. These individuals will not have full sickle cell disease, but may in some cases express characteristics of sickle cell anemia. Those with sickle cell trait will typically only experience symptoms in times of deoxygenation, which is most prominent during exercise. It is important to recognize that sickle cell trait is not a form of sickle cell disease, but that the two are mutually exclusive conditions. The sickle cell allele causing sickle cell disease and sickle cell trait is most common in those of equatorial African descent and in the Spanish-speaking regions of the Western Hemisphere. In the United States, sickle cell disease affects nearly 100,000 Americans. Sickle cell disease is present in 1 in every 365 Black or African American births in the United States. More commonly, sickle cell trait is found in 1 in 13 Black or African American births in the United States. Overall, in the United States, sickle cell trait affects 8% of all African Americans, 0.5% of Hispanics, and 0.2% of Caucasians. Sickle cell disease comes with a host of complications. These complications may be found in those with sickle cell trait as well, but are far less common and typically only occur in periods of deoxygenation or dehydration. Infection may occur due to damage to the spleen from processing sickled cells. Stroke may occur if occlusions build up in the small vessels of the brain, causing ischemia to parts of the brain. Hand and foot syndrome may also occur as a result of occlusion of small vessels that results in painful swelling of the hands and feet that is also associated with fever. Pain episodes may occur as tissues fail to receive adequate oxygen or blood vessels are occluded. Anemia results as the sickled cells died off more quickly than normal cells. Acute chest syndrome presents with symptoms similar to pneumonia, including chest pain, coughing, difficulty breathing, and fever. Splenic sequestration is the accumulation of sickled cells in the spleen, causing it to enlarge. Those with sickle cell may also experience vision loss, leg ulcers, deep vein thrombosis, and pulmonary embolisms. Sudden death due to rhabdomyolysis may also occur, especially with intense exercise and dehydration. Rhabdomyolysis occurs with excessive skeletal muscle breakdown that leads to kidney failure and death. Each of the complications discussed can be exacerbated by certain factors. Environmental factors such as extreme cold or altitude, as well as increased heat that results in dehydration, may cause sickling events. Other factors such as infection, stress, menses, and alcohol consumption may also increase risk for attacks. However, many times the cause of ischemic sickling attacks is unknown. As discussed earlier, those with sickle cell disease are in fact encouraged to participate in regular exercise. However, their participation in athletic activities is much different than that of those with sickle cell trait. Athletes with sickle cell trait should not be limited from athletic participation and can demonstrate normal to nearly normal exercise capacities. According to the American Physical Therapy Association's Sports Physical Therapy section, athletes with sickle cell trait carry a low risk of sudden death during athletic participation, except under extreme circumstances including high heat, high humidity, and high altitude. Athletes performing in these conditions should be properly acclimatized and conditioned appropriately. Those with sickle cell disease, however, must be much more careful with exercise. The CDC, who recommends exercise for those with sickle cell disease, also recommends that these individuals monitor and maintain a normal body temperature, hydration status, and rest when needed during exercise. The APTA's sports section says in regards to athletes with sickle cell disease that the athlete needs individual assessment. In general, if status of the illness permits, all but high exertion, collision, and contact sports may be played. Overheating, dehydration, and chilling must be avoided. Generally, those with sickle cell disease may participate in non-contact, non-collision sports and must be closely monitored throughout participation. This slide shows a breakdown of sports by the amount of contact required for participation. Those with sickle cell trait in general should not be excluded from participation in sports of any contact level because of their trait status. Those with sickle cell disease, however, will likely be limited to sports in the non-contact category. As discussed, those with sickle cell trait are not generally held from participation in full contact sports. In fact, there are several athletes at the collegiate and professional level who participate with sickle cell trait. However, participation in intense sports with high levels of contact and conditioning does come at a risk for those with sickle cell. In the last decade, the NCAA reported 16 deaths during conditioning, but none during practices or games. Of those 16, 63% of them were linked to sickle cell trait. Intense conditioning sessions pose an increased risk for those with sickle cell if they do not adequately self-monitor their status or are not allowed adequate rest or hydration breaks in order to sufficiently reoxygenate their hemoglobin. Most deaths during athletics due to sickle cell can be attributed to inadequate education and failure to take necessary precautions to prevent complications from sickle cell trait. Geno Atkins, a defensive end for the Cincinnati Bengals, was at first unsure of how much he would play against the Broncos in Denver in 2015. Atkins carries the sickle cell trait and was a pivotal starter in the defensive line who would be expected to play a large number of snaps during the game. Atkins had once before played in Denver, and although his role was much smaller then, during his second start with the Bengals, he and his coaches had experienced the situation before. After careful consideration, the decision was made to allow Atkins to play unrestricted but keep a careful eye on him throughout the game. In contrast to the Bengals' decision to play Atkins in Denver, the Pittsburgh Steelers have chosen to sit safety Ryan Clark during their trips to Denver. However, Clark has a history of complications from sickle cell trait when playing in Denver. In 2007, those complications resulted in the loss of his spleen and gallbladder and caused him to miss the remainder of that season. Sickle cell anemia is best treated first with a good prevention strategy. Prevention, as with many other pre-existing conditions, begins with a thorough pre-participation evaluation. Although blood tests are typically performed at or before birth to identify those with sickle cell disease and sickle cell trait, the NCAA recommends that all athletes be tested for sickle cell trait during their pre-participation examination to confirm the status. Those with sickle cell trait should avoid sudden increases in exercise intensity, as may be common during some conditioning programs. Athletes with sickle cell should complete an acclimatization program when exercising in heat, humidity, cold, or at high altitudes. Those with sickle cell should always be allowed adequate rest breaks and should avoid exercising altogether when sick or dehydrated. Athletes with sickle cell trait should take special care to avoid alcohol, drugs, and stimulants such as caffeine as well. Athletes with sickle cell trait may need to be held out of certain physical testing due to the high intensity of such workouts, such as the mile run or serial sprints, sometimes called beep tests or shuttle sprint testing. Those with asthma, in addition to sickle cell, should make sure their asthma is well controlled and supplemental oxygen should be available, especially at high altitudes. Finally, one of the best measures to prevent sudden death due to sickle cell anemia is appropriate education and preparation of athletes, coaches, parents, administration, and all those who may be directly involved with an athlete with sickle cell. Recognition of a sickling episode is a key component in the education of those involved with a sickle cell trait positive athlete. Sickling is an acute painful event that occurs when oxygen and blood fails to reach the affected tissues. Athletes may describe burning, pain, and weakness. They may experience muscle cramping, especially in the leg and back, and swelling of the limbs. The athlete may begin to hyperventilate, but not wheeze, as may be seen with asthma. They may feel overheated and excessively fatigued, and may experience hematuria, or blood in the urine. Finally, athletes experiencing a sickling crisis may collapse. Sickling crises lack prodrome or any warning signs that sickling may occur soon. Therefore, a sickle cell trait positive athlete experiencing these symptoms should immediately be treated as if experiencing an exertional sickling crisis. Cramping is a symptom of sickling, but is also a common symptom of exertional heat illness and exercise-associated muscle cramps. However, there are a few key distinctions. Exercise-associated muscle cramps begin with small muscle twinges and are usually excruciatingly painful and very localized. The athlete will typically hobble, then stop, and the affected limb will lock up. Athletes experiencing exertional muscle cramping will often collapse to the ground and writhe in pain with visibly contracted muscles. Sickling-associated cramping begins without a precursor like twinges. The cramping is usually more generalized and less localized to a single muscle or muscle group. Rather than dramatically collapsing and writhing in pain, these athletes typically collapse after slumping and falling due to weakness and will typically not writhe and yell in pain. The affected muscles will also often look normal to an observer. As with cramping, collapse is also a common symptom of other medical problems in addition to sickle cell crisis. Cardiac collapse and heat illness collapse may be mistaken for sickling collapse or vice versa. Cardiac collapse typically occurs instantaneously and is not associated with cramping. The individual will collapse without reflexive protective mechanisms, meaning they will not extend their arms to break their fall. They will also be unable to speak after their collapse. Heat illness collapse typically occurs after greater than 30 minutes of intense exercise, and an elevated core body temperature will often be found. Sickling collapse typically occurs after less than 30 minutes of intense exercise and involves cramping but no elevation in core body temperature. Treatment for sickle cell disease requires ongoing medical treatment and monitoring. Those treatments are beyond the scope of this presentation, however, should be reviewed if you are working with an athlete with sickle cell disease. Those with sickle cell trait are followed medically less vigorously than those with sickle cell disease, but it is essential that medical personnel be prepared to administer treatment in the event of a sickling crisis. Those suspected of experiencing symptoms of sickling should immediately cease exercise and report symptoms to their athletic trainer, coach, or supervisor. The athlete should be allowed to rest and rehydrate, and if necessary, be administered high-flow oxygen at a 15 liter per minute rate with a non-rebreather face mask. Vital signs should be monitored in order to track progress or decline. If symptoms do not improve or the athlete collapses, the emergency medical system should be activated, as this is now a medical emergency. As an athletic trainer, you may be the first person to recognize that an athlete is experiencing a sickling crisis. Every effort should be made to educate those who will be involved with conditioning practices in order to prevent sickling events and recognize them when they do occur so that appropriate action is taken. As an athletic trainer, it may also be your responsibility to appropriately identify all athletes with sickle cell trait prior to athletic participation. Once identified, it is also essential to begin an open line of communication with the athlete and their family and to confirm that the condition is being managed appropriately by outside medical personnel in addition to the athletic training staff. If an athlete is identified with sickle cell anemia, it is also essential to begin communication with the team physician and local doctors so that in the event of a medical emergency, they may be prepared as well. The decision for return to play should be a team decision made with all members of the medical team. Return time depends on severity and duration of the sickling event and the speed of recovery from it. As discussed, Ryan Clark of the Pittsburgh Steelers was unable to return for the duration of his season after a sickling event due to the magnitude of his complications. Each event and each athlete should be considered individually. Thank you for your attention during this presentation. The National Athletic Training Association, the American Physical Therapy Association, the Centers for Disease Control, as well as the National Collegiate Athletic Association are all good resources for information for medical personnel, parents, athletes, and coaches regarding sickle cell disease and sickle cell trait.